Hi everybody, welcome to my YouTube channel Dr. Sreenivas Medical Concepts and my FB page Dr. Sreenivas Concepts. This is Dr. Sreenivas, neurologist from Rajahmundry, Andhra Pradesh, India. My email is sreeklpm@gmail.com. I am also the medical author of the two books Focused Neurology and Exam Oriented Clinical Neurology. We are continuing with a series of lectures of prime neurology. There are going to be about 50 episodes of prime neurology, and if one listens to all these 50 episodes of prime neurology, one would have acquired a good knowledge of neurology. Right now we are on part 36 of prime neurology, CNS infections, part 1, bacterial meningitis. So today in this episode we are going to discuss bacterial meningitis. Bacterial meningitis. This is a bacterial infection of the pia and the arachnoid and the cerebrospinal fluid that they enclose. Since the subarachnoid space is continuous around the brain, spinal cord and optic nerves, an infective agent or blood or tumor cells gaining entry to any part of the space spreads to all of it. Thus, meningitis is always cerebrospinal. Etiology: Streptococcus pneumoniae, Neisseria meningitis, Haemophilus influenza, Listeria monocytogenes. These are the most common bacteria causing meningitis. Meningococcal meningitis. This form of meningitis is most frequent in children and adolescents but can occur throughout adult life. Haemophilus influenza meningitis affects mainly children between the ages of 2 months and 5 years but is being reported increasingly in adults over 50 years of age. Its incidence in children is diminishing in developed countries as a result of vaccination programs. Pneumococcal meningitis predominates in the very young and old and has a predilection for patients with sickle cell anemia and those who have had a skull fracture or splenectomy. E. coli, Staphylococcus aureus, Group A Streptococci, Klebsiella, Pseudomonas, Proteus, and Listeria monocytogenes are associated with immunodeficiency states, trauma, and neurosurgical procedures, including ventricular shunts. The pathogenesis and pathology: invasion of subarachnoid space by meningeal pathogens, multiplication of organisms and lysis of organisms by bactericidal antibiotics, release of bacterial cell wall components including endotoxin and teichoic acid, production of inflammatory cytokines which causes alteration in the blood-brain barrier permeability, adherence of leukocytes to cerebral capillary endothelial cells, alterations in cerebral blood flow, production of excitatory amino acids and reactive oxygen and nitrogen species. This increases the permeability of blood vessels with leakage of plasma proteins into CSF. Exudation in the subarachnoid space obstructs the outflow and resorption of CSF and surroundings and infiltrates cerebral vasculature. This causes obstructive and communicating hydrocephalus and interstitial edema. There is also vasogenic edema. The leukocytes migrate into the CSF, degranulate and release toxic metabolites, causing cytotoxic edema, stroke and seizures, which increases intracranial pressure and leading to coma. There can be alterations in cerebral blood flow. There is production of excitatory amino acids and reactive oxygen and nitrogen species causing cell injury and death, which also causes increased intracranial pressure and coma. So this is the pathogenesis and pathology of bacterial meningitis. The clinical features: fever, severe headache and neck stiffness, generalized convulsions and various degrees of drowsiness and confusion, sometimes progressing to coma, are the usual manifestations in adults and older children. Seizures occur more often in infants and young children. The signs of meningeal irritation: 1. Kernig sign, 2. Brudzinski sign. What is Kernig sign? Inability to completely extend the legs. Brudzinski sign: it is stiffness of the neck on forward flexion with flexion of knees and hips which become evident. The clinical clues: certain clinical clues may indicate the type of meningitis. Petechial and purpuric rash and circulatory collapse. It indicates meningococcal meningitis with Waterhouse-Friderichsen syndrome. Ventriculoatrial or peritoneal shunt, cranial trauma or neurosurgical procedure. It indicates coagulase negative staphylococcus or other nosocomial organisms. Upper respiratory and ear infections in children, Haemophilus influenza. Immunocompromised state Streptococcus pneumonia, Listeria monocytogenes, E. coli and mycobacteria. Infection of ears, sinus, lung, heart valves in adults. Streptococcus pneumonia or mixed infections including anaerobic organisms. The cerebrospinal fluid, the opening pressure, the cerebrospinal fluid abnormalities in bacterial meningitis. Opening pressure may be more than 180 millimeters of water. White blood cells predominant, especially neutrophils, 10 to 10,000. Red blood cells absent in non-traumatic trap. Glucose is decreased less than 40 milligrams per deciliter. The CSF by serum glucose is less than 0.4. Protein is increased more than 45 milligrams per deciliter. Gram stain is positive in 60%. Culture is positive in more than 80%. PCR, polymerase chain reaction, detects bacterial DNA. The treatment, the antimicrobial therapy, the organism and the antibiotic we use. For Neisseria meningitis, which is penicillin sensitive, penicillin G or ampicillin can be given. If it is penicillin resistant, we give ceftriaxone or cefotaxime. For Streptococcus pneumonia, it could be penicillin sensitive, penicillin intermediate or penicillin resistant. For penicillin sensitive, we give penicillin G. Penicillin intermediate, we give ceftriaxone or cefotaxime or cefepime. Penicillin resistant, ceftriaxone or cefotaxime or cefepime plus vancomycin. If it is gram-negative bacilli except Pseudomonas, we give ceftriaxone or cefotaxime. If it is Pseudomonas aeruginosa, we give cefotaxime, cefepime or meropenem. Staphylococcus species methicillin sensitive, methicillin resistant. If it is methicillin sensitive, we give nafcillin. If methicillin resistant, we give vancomycin. Listeria monocytogenes, ampicillin plus gentamicin. For Haemophilus influenza, we give ceftriaxone or cefotaxime if beta-lactam is positive. Ampicillin if beta-lactam is negative. For Streptococcus agalacticia, we give penicillin G or ampicillin. Bacteroides fragilis, we give metronidazole. And for Fusobacterium species also we give metronidazole. So these are the wonderful concepts of bacterial meningitis. The other interesting concepts of clinical neurology I put in a book called Exam Oriented Clinical Neurology, written by me, Dr.Sreenivas, published by White Army. This book will be very useful for students appearing for clinical neurology exams. So if interested, this book could be purchased. The other book I wrote is Focused Neurology, written by me, Dr. Sreenivas. This contains all the essential elements of theoretical neurology, put it in a question answer form. This book is published by CBS Publishers and Distributors. This book is available online from all leading booksellers, including Amazon. If interested, this book could be purchased online. As I said earlier in my lecture, there are going to be 50 episodes of Prime Neurology, and if one listens to all these 50 episodes of Prime Neurology, one would have acquired a good knowledge of neurology. Just now we are done with another episode of Prime Neurology. If you have liked it, please like, share and subscribe to my YouTube channel, Dr. Sreenivas Medical Concepts, which is India's leading neurology educational YouTube channel, and my web page, Dr. Sreenivas Concepts. Thank you. Bye.